So I believe the first person on our list is Darrell J. Fox, who is the Minority AIDS Initiative NEHEC Project Director. If you'd like to join us, we'd love to hear your comments.
Hello, everybody. Hope you can hear me well. Get a little nervous when I talk to people at first. The report and the questions from this group was excellent, considering the level of debate we have to do today. Because I am a little nervous, I'm going to read my comments and try to stay on point. I thank the CPAC, the ICER CPAC group for choosing to focus on CHWs during this public meeting. My verbal comments are meant to augment my written comments, about 6 pages or so, that I previously submitted before the deadline. In my written response, I gave a little more background on myself, but I've been a community health worker for over 22 years, and 20 of those years was spent on a clinical team at a comprehensive adolescent HIV program called Boston Habits at Children's Hospital. In the words of Stephen Pearson, president of ICER, he said, hopes are high for community health, that community health workers can be effective delivery system interventions to improve access to care, reduce health disparities, and improve appropriate healthcare utilization. I feel the evidence exists to demonstrate that CHWs are effective and efficient in improving access to culturally and linguistically appropriate and competent care, reducing health disparities, and also improving appropriate utilization of healthcare. Although I commend CPAC for your focus on CHWs, based on my understanding of your review process, I'm not sure the evidence, and it's played out at this table, is going to be good enough to give you the evidence that I know of our high and reasonable value. We are a unique workforce. We are part of the public health workforce, putting public health theories, including stages of change, behavior, cluster theories, motivational interviewing, Prochaska, DiClemente, all those wonderful guys, on the ground, putting them into practice on the ground in practical ways. CHWs are practitioners of primary and secondary prevention. CHWs also are part of the community development and community capacity building workforce related to our work addressing social determinants of health on the individual, family, and community level, as well as through health, wellness, and education. CHWs are invested in identifying and addressing the root causes of illness in partnership with our clients, their families, and our communities to provide sustained solutions. CHWs are also unique that we are also part of the clinical care workforce and part of the clinical care team in our role as healthcare prevention specialists, chronic disease management professionals, cultural brokers, agents of change, partners in clinical care and management, patients and system navigators, educators to clinicians related to the community and cultural issues faced by the clients. We're also resource specialists, just to name a few of the hats that we wear in some of our core roles we play in the clinical setting. In other words, we have our foot and respect and value and have learned experience navigating the streets, which is also known as the community and the population health, the exam room, most appropriately usually the waiting room, where we are in the clinical world, and then the boardroom, rooms like this, rooms of legislators, policy makers, and administrators. What is clear, as the title of a recent CHW article published in Health Affairs says, CHWs are part of the solution to what ails this country's healthcare, human service, and public health systems. None of the 1-year duration randomized clinical trials that I know of can truly capture the breadth of the impact, the return on investment, the cost savings, or appreciate the full value of the effectiveness, the comparative effectiveness of CHW interventions. And I want to note, because I heard a comment, we are in it for the long haul. In my 20 years as a CHW, I had many grants that came and went, but I'm sorry, emotional. But I stayed in it with the families that I served. Sorry. All right, back on cue here. A lot of the partners across the country in CHWs as well provided some written feedback and also some additional information, studies, and references that are in addition to the over 140 references you cite in your report. Among those providing materials prior to the draft report and also feedback after the report was published was our New England Regional CHW Coalition, which includes CHWs, allies, and partners, employers, as well as a lot of representation from HHS Region 1 offices representatives. We hope the council has and will use some of that additional materials during deliberations and also try to integrate, and some of the discussion here was about that, reduced ER usage and our impact on that.
If I could ask you to...
access to wellness. In this critical time, I'm going to close, in this critical time in our region around transformation of systems and care, around accountability, integration of public population health and clinical care, CHWs are the bridge, the link, and the ties that bind these worlds together. And as great theologian, also known as the rap group De La Soul said, the stakes is high, you know the stakes is high. The stakes is high, we know the stakes is high. I feel that your report will be looked at. I hope you guys can get it right, and I urge you to look at the high value of CHWs, and I thank you very much for your cooperation.
Thank you very much for your comments. I would ask our CPAC members if they have any questions they'd like to address to our speaker. And if our speaker could come back to the mic.
Darrell.
Come on back to our microphone for a
I'm
second.
sitting on my hand close to the speaker.
Okay. We have time for just one or two brief questions, if possible.
Thank you. Thank you for the presentation. One of the things we were getting hung up on was the caseload issue, because I think that really when you look at the single biggest fixed cost of any of these programs, it's the cost, your salary for your health worker. And when I saw the 192, and then I'm doing the math, I'm thinking, well, let's see, if they're spending an hour with each client, 1 to 2 days, it just didn't add up. So I'm curious about your experience, maybe not just necessarily with HIV programs, but with others. What would you say an average caseload is for a health worker?
It can range around 100, because what happens is there are some people who are actually lost to care, sometimes that we actually go out and seek. Mm-hmm. But the people who are in regular care, who are getting small doses of CHWs and who need small doses, that can range in the 75 to 100 group. While there's usually a smaller subset that is our more intensive group of people that might range in the 30s to 40s.
Thank you.
And there are some CHWs who might just focus on just that population, so they would have less of a number, versus those of us who focus on the broader general population who would have a bigger caseload.
Thank you.
Any other, one other quick question? Okay, why don't we move on? Thank you very much. Next is James Corbett, JD, System Vice President of Community Health and Ethics, Steward Healthcare.
Thank you. Well, thank you for the opportunity to speak. I want to start by saying I didn't know De La Soul was a theologian, but when I went to school, I'm going to write them and let them know that. So I'm a Vice President of Steward Healthcare. I'm also an ethicist at Harvard Medical School. I'm in an ethics fellowship program there, and I actually teach at the University of Maine School of Law here, actually. Before this job, currently, I was at Mercy Hospital, so I was coming back home. Here to talk about a couple of different things. We started a community health program at Steward Healthcare. Steward Healthcare is a for-profit health system in Massachusetts with 11 hospitals in the state. And for me, particularly working in a for-profit health system, was really important to focus on both the social and the financial. But I started with a financial argument to build it. So I went to the CFO and I said, I want to hire community health workers. And he said, why would we do that? And I said, I think there's an opportunity here to reduce our charity care and bad debt by looking at the community health worker potential differently. So we stratified the bad debt and charity care by language, and we started to see certain trends of those who, higher debt with those with different languages. So we then hired community health workers based on the languages per hospital in the community, and by doing so, we're able to have them partner in the emergency room. So the patient comes into the emergency room uninsured often, even in a state like Massachusetts where people fall off and on the rolls. This person came to the ED, had an issue. At times they don't come with the pay stubs, the ID, all those things. So what happens is that visit is not paid for because the application is never completed. But if you can get that application completed, you can then have that visit paid for. So what we did was give them iPads and send them into the community, and they went to the patient's homes and finished that application process. By doing that with 5 community health workers, we brought back $2 million to the system in 1 year. And I wrote an article on it, which I brought for the group, and I'll leave it for the folks to talk about it. It's entitled Doing Good and Doing Well, Corporate Social Responsibility in Post-Obamacare America. Because I think the opportunity is for us to think about it socially and financially. And I guess some of the conversations that we've had here today are a bit challenging because it's a difficult, we live in this structured schizophrenia, right? We're a fee-for-service at one time and we're at full risk at another on some patients. So when you think of the cost benefit, on the fee-for-service side, some of these things we're saying is a cost benefit don't necessarily benefit those who are on that fee-for-service model. So I think if we're really talking about the sustainability of the program that can help not only vulnerable patients, but vulnerable individuals looking for jobs, we've got to double down on the funding and double down on the cost aligned with the provider. Even when we're thinking about the provider here, putting them in one bucket, I think is a challenge. I think we've got to separate hospitals from primary care practices and community health centers who are more likely to have primary care, more likely to have community health workers in place. A couple other comments and questions is the question on the effectiveness of the program. I think we got into it a little bit. We talked about this challenge of looking at clinical interventions only or financial benefits only. But we all recognize that the social, behavioral, and environmental determinants of health are one area where we think the community health workers can have the most impact. I guess the question is how you look at those interventions and then see, because of those interventions, what's the cost, or because of these social interventions, how's that connected to clinical outcomes? But it almost seems like reverse to start with what are the clinical outcomes as a community health worker without connecting the dots more fully. And then lastly, I just implore the group to figure out a way to maybe not limit public comments if at all possible, because I think there's a lot of people who aren't going to write the articles, and we all talked about the challenges of these studies, but I think unless we figure out a way to dig deeper, we're going to have over-rely on studies. And then lastly, if there's ever a way to figure out a way to have more diversity around the table when we have these type of conversations. Thank you.
Thank you. If you could say it's Mike. Any questions from the CPAC members?
I have a quick question. So do you use community health workers in the physician practices, or are they really just based in the ER?
So we look at it with 3 different buckets. We say the first one is the insurance enrollment, and we think with Medicaid expansion is a national opportunity to use community health workers there. The second one is the care coordination, and that's the bucket where we start working closely with the primary care practices. And for us, the third one is care coordination. We're training them skills such as ESPER and motivational interviewing. I will say that the second and third, care coordination and care management, those are kind of a softer analysis for the dollars, and those are the programs, no matter, unfortunately, how great these programs do. When the grant runs out, they end. And on the insurance side, you can make a direct connection between reducing bad debt and charity care, and that sells well with CFOs.
Follow-up question on that. Are these the same bucket of patients, the ones who come into the emergency department, who you're first enrolling, if possible, and then putting in some kind of a care management program at the coordinating their care at this, utilizing community health workers in what role, and how are you integrating with a medical team, or how are you working that?
Okay. So on the first one, the first point of entry is the emergency department, and there's financial counselors in most hospitals who are starting to enroll folks. And what this person was able to do, the community health worker, was be a part of that team in the emergency room, but then go into the community and go into the homes and jobs of patients. And when they were doing that, not only did they get folks enrolled, but insurance enrollment alone didn't do it, because they were still coming back to the ED, we realized. So we then had to coordinate that, make sure that same person who then had a relationship with this individual and their family members, oftentimes they were there to enroll one person, they go to the house and there's 10 people waiting for them. The next step was to get them connected with the primary care practice. So with that, we worked closely with the primary care practices to do that. In the third phase, we're just enrolling now, but we've had some interesting things happen with the care management side. We're delivering healthy meals to some patients. Again, these patients who are full risk, we're full risk for, we're delivering healthy meals to them. And the community health workers are actually going into the house doing what we call a fridge inspection. So in addition to delivering a 30-day meals, healthy meals, we have somebody in the house kind of following up that message, because the big key is behavior change, as we know. They drop a healthy meal, but if folks aren't going to eat it, then it didn't do much.
Any other questions from CPAC members? Ellen?
Yeah, I hesitate to ask this, but of your savings, I'm channeling Rob right now as a Medicaid director. Is your savings getting them off the books onto Medicaid, so you're getting paid for them, or is your savings through utilization? And please say the latter.
Well, so I think this goes to what I was getting at. I think we have to have a nuanced conversation about what the savings is. So for us as a system, there's savings when they're uninsured or enrolled in insurance. And in a state with universal health insurance, we need to do a better job of doing that. And we all understand that insurance means you can get to a primary care practice, which means you'll probably have more usual source of care, which means that savings can be translated to the system. In terms of the frequent users of our ED, that's another savings, right? So those folks who are cycling in and out of the ED, we wanted to make sure they got to a primary care. But again, if we're fee-for-service on this population, not necessarily a savings, maybe even a loss. So it's important for us to craft it more. I just think that the savings can be for the system and for the insurers, but we've got to just make sure that we're looking at the interventions and connecting them to the different affected parties. To answer your question, yeah, definitely a savings for the system, putting folks on the insurance enrollment. Definitely a savings, I think, for the insurers long term, because the folks are not cycling in and out of the ED.
So it was the latter. Good.
Another
One
question.
quick question, if I could. Thinking about all of the focus on readmissions and the health coach within the CTI model, and I've been wondering about the relationship between the CHWs and that health coach role. Are the CHWs being deployed in a way that is sort of a health coach plus, or is it part of a framework with their training? If you could inform that, that would be helpful to me.
That's great. So for us, we've been pretty fortunate. So we're a Medicare ACO. So we are with certain populations, and again, we're unfortunately in a position at times where you're putting more resources in certain populations than others. But we are able to allow our community health workers to be part of the care team that manages the full risk populations. So they've actually, recently, there's a health system management system we have in place where all the care managers and the doctors and others are looking in. Most recently, we built a screen there for the social interventions that community health workers could put in place. So they're all seeing these different interventions together and seeing the value of community health worker interventions.
Terrific.
One more question.
James, thank you. Just a question, we've heard incentives around the table more than once, and just was curious as to whether in the course of these interventions in the patient's home or perhaps through the wider community, you folks implemented some incentives-based programs, and whether those worked.
For the patient.
For the patient.
So incentivizing the community health worker or incentivizing the patient?
Incentivizing the patient
Yeah.
to either respond with their experience, to follow up, say, with the necessary paperwork.
Yeah. So, that's a hard, we're talking about behavior change at the end of the day, and that's really the hardest thing. So we knew that we couldn't, the data was indicating that certain populations weren't going to ever come back. So the inspiration was really on our end to get them. They didn't have, anecdotally, they didn't have a lot of concern about another bill coming. I mean, oftentimes, they're not even going to open the letter, and we recognize that. It was much better to have a community health advocate go into the community and work with these folks and have the business office call and say, did you finish your paperwork? But in terms of the incentivizing of the patients, back to this community, back to this Healthy Meals Delivery Program, we're putting it in place for congestive heart failure patients who are at risk of returning to the ED. So we're delivering low sodium meals. So the incentive there for us was working with the community health worker to have those one-on-one conversations with the partner and also the mate. We started the program thinking we deliver one healthy meal, but we recognized that if the mate is not eating that same meal, then the program was going nowhere, so we had to put both in place. And the incentives really came from the relational. They started to connect with them. They look like these people. They speak the language. They live up the block. One lady's called a Mass Health lady. She's helped her get Mass insurance, Mass Health insurance. So the incentives are only, I think, are more relational. There weren't incentives that we could put in place that then could motivate them based on desire for us to see how we'd like them to live. But for me, it all starts with meeting people where they are, not where we want them to be. So where they are is different in different communities based on their different issues.
Thank you.
Thank you very much. Our next speaker is Stacy Chacker, who is Health Resources in Action.
Hi, my name is Stacey Chacker from Health Resources in Action, and I direct the Asthma Regional Council. We are a council of New England, which is based on addressing the high rate of asthma, working to improve both clinical and environmental addressing asthma. I'm also nervous, sorry. So anyway, first of all, I want to thank you for your study and your focus on the effectiveness and value of CHWs. We realize that you're looking at CHWs very broadly, but because of your focus on asthma, we really felt compelled to focus our comments on asthma. And you have received comments that I wrote on behalf of our council. We have sign-ons. We would have had a lot more sign-on if we had more time. And also you received the updated comments from Dr. Krieger, as well as Nurma Gavatat from the CDC. And so I just want to express some of our concerns. We really appreciated your focus on the value of CHWs and in terms of improved health outcomes. As you know, we're really concerned about your analysis of the budget impact. And I have some comments. One is your focus on your extrapolation based on persistent asthma. Not all kids with persistent asthma need home visits. In fact, we would argue that it's really the kids that are poorly controlled or not well controlled that could really benefit from home visiting. Children with persistent asthma are often controlling their disease. The second thing is just the comment that generally community health workers that are doing home visits for asthma, it's generally 3 to 5 visits over a 6-month period, or it can be a 6 months to a 12-month period. And really the focus is generally on doing education about asthma. It's about doing an assessment of the home. It's providing supplies, and we would argue that the supplies are really durable medical equipment, as you've kind of indicated, that when you're buying a vacuum cleaner, which generally costs around $100, is that those are supplies to help the family manage the asthma and to address the environmental conditions in the home. Just to let you know, we are actually right now, we have a grant from the Centers for Medicaid and Medicare Healthcare Innovation Award that we are working on in 4 states right now with 8 medical institutions with the CHW asthma intervention to demonstrate both cost effectiveness and improve health outcomes. And we are delivering supplies that are around $350 for each family that include a variety of supplies. In the comments that I submitted, you'll see that Children's Hospital has done a study that included a nurse as well as a community health worker, which one could argue would be a more expensive intervention, and they were demonstrating a $1.33 return on investment, as well as a social return on investment. In terms of Beck's comments on the report from the CDC, there was a comment and a question about missed school days, and an average from the 20 studies that were done that were not just CHWs, that there's an average of 21 decreased missed school days. Also decrease in symptom days. The pediatricians that we work with also advocate that there's a benefit to the entire family. When you're addressing environmental conditions in a home, it's not just the child with the asthma that is benefiting, it's also the other children in the family or the adult in the family that might also have asthma that are benefiting from this. And I do think that we need to think about the long-term benefit, because when the family is educated about their child's asthma and understands the conditions, they're better able to deal with the conditions that impact this child's asthma. And I think about one of our parent asthma leaders from a coalition in Boston that talked about her kipping in and out of the ER all the time until she finally moved somewhere and understood it was about the carpeting in her home. And she was able to address the condition. And so when families are able to address a condition, they want their kid out of the ER. They want to go to school. And so they are able to have a long-term benefit when they can understand what the trigger is for that child. I probably have 10 other things to say.
Yeah, I'm going to have to ask you to wrap up for now.
So that's it. I just ask you to really include a more global perspective. And when you're voting on this, we understand you're voting on CHWs in general, but I think it's really important that each intervention really is different. And we support general CHWs, but also different diseases are really complicated. And asthma is a really great example. It's a really complicated disease, and people really need to understand it. And so we think there needs to be generalists, but there also needs to be specialists in the field.
Thank you. Any questions from CPAC members?
Great. Yes. Sorry.
Well,
So you heard us focus on the Krieger study.
Yep.
And that program. So help CPAC understand, is that program more expensive, more intense than the average asthma CHW intervention? How would you compare its intensity, expense, complexity
Actually, I don't.
to the real world?
To the real.
To your real.
Well, I think in the real world right now that a lot of the CHW asthma visits that are being done are part of grant studies and evaluations. And I think studies and evaluations cost more money, I know because we're doing one right now, than just an intervention. Because when you're working on just an intervention, you're not working on the fact that you're collecting data that needs to be very specific, and you're going through protocol. We have spent a lot of time this past year developing protocol, questions, follow-up, systems for collecting data. I know that there's several health plans. If you refer to one of our business cases, there's health plans that are doing asthma home visiting, both with CHWs and with other clinical providers that look at asthma home visiting that have showed cost effectiveness or return on investment. I think that generally you will find that home visiting for asthma has a range of between 1 and 5 visits.
Thank you. Any other quick questions? We have 2 more speakers.
To the issue of how persistent the effect of the home visiting is after you stop doing it, do you need to continued intervention?
So generally, these interventions are a one-time intervention. It's,
And the effect persists?
So Children's Hospital has published their study that has looked at going back 3 years post-intervention and has showed continuing benefits to the family.
Thank you. Thank you. Okay. Our next speaker is Heidi Ben-Farouz.
Hi. So I just wanted to state, as someone who's kind of directed a community health worker program for about 20 years, and we talked about some of the problems with the data sources, but there were a couple of things that I wanted to point out. One is that those of us who are doing this work in the real world setting often have difficulty doing randomized controlled trial or having a comparison cohort. And that there's a lot of great data out there that we couldn't look at, and albeit we have to be careful in terms of being able to apply the same rigor, but that some of the pre-post analysis, even though limited, is fairly significant in my view. The other thing is, and we mentioned this, that community health workers, I think it is good to think about them as interventionists integrated into a model of care or a team approach. And one of the things that we didn't talk a lot about today when we were presenting the data were the care coordination attempts, the complex care management, which is going to be huge when we start thinking about accountable care and achieving the triple aim. And just as an example, in the JAMA yesterday, there was an article that came out about the Medicare population and some of the studies that have shown that our initial intent in terms of reducing costs in this population by reducing emergency room or inpatient stays isn't going to get us where we need to go as much as it is keeping people in the home and reducing nursing home costs. And I wanted to point out a study that was actually included in the report by Holly Felix in Arkansas, where they actually used just 6 community health workers with about 900 patients and compared it to a cohort of 900 high-risk patients that Medicaid identified through their criteria for being nursing home susceptible. And actually what they found with the CHW is just connecting and getting them home services in place to keep them in the community, that for the $1 intervention that Arkansas spent, the state of Arkansas, that there was about a $3 return. So net savings to the system of about $2.6 million. And Arkansas is now interested in really expanding this model beyond the population. So I think as our population is aging and we're thinking about long-term care, this is something to think about, another application of community health workers in terms of keeping people out of institutions. The other thing I would just say is that when we look at the data, a lot of published data are coming out of academic medical centers. A lot of CHW interventions aren't occurring in those settings, and I think we'll talk about this later in the panel, but what do we do to kind of buttress the support of study of complex interventions in the real world? It's not just applicable to CHWs, we're talking about a lot of different things. And one other kind of domain that I just wanted to talk about was that when you're thinking about your votes, I liked some of the things, the training, the in-home visits, link visits, et cetera. One of the things I would encourage us to think about, though, is when we're talking about training, we're not just talking about training of CHWs. We're talking about training of the team that needs to use the CHW. And so that when you're thinking about building that, one of the huge problems is that the system doesn't know how to use community health workers well. And you can't really judge CHWs for the failure of the system to integrate them effectively. And along that line, also thinking about what is the supervision model and the improvement efforts, the outcomes to which the CHWs are being held, needing to be measured. And I think we should talk again more about, and this has come up before, we're doing a lot of apples and oranges comparison. What is our target population? What is the scope of work of the CHW? And how are they integrated, where are they seated as CHWs? These are things to consider.
If you could
And then
wrap up,
I
I'd
would just,
appreciate it.
end by just saying that I think some of the other work, and I believe Dr. Zabowski mentioned this, that we aren't seeing, which is going to become a huge issue for us in terms of policy implication. It's a huge amount of work that CHWs have done with the SKMI population and keeping people out of institutions there, that we also have to look at that aren't included in these studies.
Thank you. And if you can remain at the mic, any questions from our CPAC members? Okay, thank you very much. And I think we have time for one more. Oh, wait a second, guys. We have, there's one other late person who would like to speak. Lisa Roney Holderby?
Lisa Renee.
Excuse me, Lisa Renee Holderby Fox.
Yes.
I apologize. Who is Director of the Massachusetts Association of Community Health Workers.
Good morning, or good afternoon now, I guess. But I just really want to thank CPAC and ISA for really taking a closer look at CHWs and who we are and what we do. I want to say first and foremost that I am a CHW. I've been a CHW for 20 years. Like some other CHWs, some other cohorts of mine, I have never worked for a healthcare delivery system. But that didn't mitigate my role at all as a CHW in communities with families. And so I just really want to encourage you to please, please, please remember that I understand that you're focusing right now on medical interventions and how CHWs complement those. But I would urge you to remember that the report that you produce in the end is going to have huge impact for our workforce. And we don't want to leave out a huge segment of our workforce in the end. The other thing that I'd like to say is that, we welcome evaluation, we welcome research, but it's just very important that we're not comparing apples and oranges, because again, the impact that that's going to have, not only for our workforce, but for the communities that we serve, could unintentionally have some detrimental effects. And then just finally, the education component. It's crucial that CHWs have education to be able to move forward, to offer our unique contributions to the healthcare delivery system, the human service delivery system. And I know that you all will be thinking about that later on and making a vote. And I just really please urge you to remember how important education is for other public health professionals, and to remember how important continuing education is for other public health professionals as you vote and deliberate on that. And then just the very last thing I'm going to say, and thank you for accommodating me, the very last thing I'm going to say is that I know that we also have focused a lot on very specific illnesses and diseases, and when we talk about training and education for community health workers, it's very important, in fact it's crucial, that we all have core competencies, baseline, that then we can add expertise, additional expertise to in the future. So again, please, I urge you as you move forward and make your votes this afternoon, that you think about not only the financial impact that this may have, but also the social and moral impact that community health workers bring. I'm sorry to become a little emotional about this, that we bring to the table, and the important value that we add to health teams. Thank you.
If you could stay at the mic for a second in case, if there are any questions. And actually, I have a question in regards to what type of formal training structure do you have for your program?
Sure, and let me just clarify a little bit. I head up the statewide professional association for community health workers. So I'm not an employer of community health workers. We're a statewide professional organization, just like many other professions have. I will say, though, that we work very closely with the training entities that are currently existing in the state of Massachusetts. And those are approximately 45 to 54-hour training programs, core competencies, and then the opportunity to have some additional expertise in various health-related topics.
Thank you. Questions from any CPAC members? Thank you very much.